So good morning, good afternoon, good evening, everyone. We are so excited that you could join us today. And I want to give you a heads up that this meeting is being recorded for people that couldn't join us today. I know that there are about 200 patients, family, and friends that have signed up for this webinar from over 23 countries. That is amazing, and we are so glad that you could be with us. My name is Marnie Kaufman, and I am co-founder and director of the Adenoid Cystic Carcinoma Research Foundation, or ACCRF. And I am incredibly excited to have so many of you people joining our second webinar. Like many of you, I had to learn about ACC after feeling undiagnosed pain in my neck for over 12 years. Then in 2004, I was diagnosed with a tumor in my parotid gland that had invaded my facial nerve. I immediately had surgery to remove the tumor and the lowest branch of my facial nerve. And then I had 7 weeks of photon radiation. Whether you are an ACC patient, caregiver, family member, or friend, we are sorry that you have had to learn about ACC, but we are so honored that you could join us today. During our inaugural webinar, we surveyed the community to see what topics you would like to see addressed in future webinars. Systemic therapy in ACC was the front runner. And so that's why we have put together this amazing panel. And we're so grateful and honored that Dr. Hanna and Dr. Ho have agreed to give up their Saturday morning to be here with us. In my personal opinion, they are two of the smartest and most compassionate doctors that I have ever met. We are so lucky to have them helping ACC patients. Could I have the next slide? After I give some initial thoughts, my husband, Jeff, will explain ACCRF's role in systemic therapy. Then Dr. Nicole Sparty-Burr, our Director of Research, will introduce our esteemed panelists, who will each tell us a little bit about their work. This will be followed by a panel discussion with Dr. Hanna, Dr. Ho, Jeff, and Dr. Sparty-Burr. Finally, I'll hope to wrap things up and get some feedback from you all. Next slide. We have a few housekeeping issues to go over. So first, the questions for the panel are drawn from the registration forms that you all used, but please feel free to continue to add questions to the chat. Dr. Bojo Todoric, another ACCRF board member, will be monitoring and recording those questions that we'll try to address if time permits, but we won't be able to address questions relating to any individual patient. So please don't put any personal information like your medical history into the chat. And we ask that you don't copy any information from the chat and distribute it. ACCRF does not provide medical advice. All treatment decisions should be discussed with an experienced physician in a private setting. And comments in this webinar refer to broad patient groups and not to individual patient. Once again, it's being recorded because there were some people that couldn't join and we want everyone to be able to watch it. Now I've checked housekeeping off the list, and I want to remind you that today we're focusing on patients that may need to consider systemic therapy because they have recurrent or metastatic disease. But not every patient will need to consider systemic therapy. About half of ACC patients will not have recurrences or metastases. I consider myself incredibly lucky to not need systemic therapy, but I continue to be watchful and have regular scans and follow-ups with my treatment team. ACCRF is here to support all ACC patients, whatever their individual ACC journey, and today we're proud to focus on systemic therapy. With that said, I'd like to introduce Jeff, my much better half, husband, father of our 4 sons, and executive director of the ACCRF.
Thank you to my better half. Hello, everyone. I'm Jeff Kaufman. I'm the executive director of ACCRF. Now, some of you may not have joined us for our first patient webinar in November when we gave an overview of ACCRF's research activities. So I'm going to spend a few minutes providing some context for today's discussion and how systemic therapy is central to ACCRF's efforts. The first patient webinar is on our website homepage, so you can watch that at your leisure. Now, Marnie and I founded ACCRF back in 2005 after her diagnosis and initial treatments. This picture shows us the week before Marnie's surgery. We had 4 boys under the age of 10, so we were both exhausted and driven by a sense of urgency that only patients and their families can have. We pulled together a world-class group of oncologists who have helped guide the global ACC research effort. ACCRF's mission is very simple. We want to get to better treatments and a cure for ACC as quickly as possible. Now, how do we get there to the top of this pyramid? Well, we believe it involves developing a pipeline of clinical trials of systemic therapy based on the best available science. Such clinical trials don't appear out of thin air. We worked hard with patients and researchers to create a community that supports coordinated research. That is the base upon which we built our strategy. As you can see from the slide, clinical trials of systemic therapy lie at the center of what ACCRF coordinates. Oops. Our research agenda begins and ends with patients. Nothing can be done without patients donating specimens, their medical records, and funding. Patients describing their treatment goals, and very relevant to today, patients participating in clinical trials. Only once the input of patients is there can researchers work their magic and press towards better treatments. Most patients may see only the end of the process, back over here, in the form of a clinical trial of a systemic therapy. But before then, there's the painstaking work of gathering and developing the biobanks and preclinical models, finding molecular targets through cutting-edge genomics, further studies to identify mechanisms and drugs that can stop or reverse ACC, and testing the drugs in preclinical models. Of course, we hope that the outcome of all this effort will be better outcomes for ACC patients, and I believe we're getting there. As you can see from this slide, the last several years have seen strong growth in ACC clinical trials. We're so thankful to the brilliant and dedicated medical oncologists, like our guest panelists today, for making that happen. And especially for the many patients who have let their journeys be documented so other patients may learn what works. I won't go over in detail the next slide that lays out the landscape of ACC clinical trials. The main point is that many types of drugs and combinations of drugs have been tried, going after several key molecular targets in ACC. And many additional efforts are currently being undertaken in a methodical and science-driven way. You can review the history of ACC clinical trials on our completed studies webpage, which is highlighted here in red at the bottom. And you may wish to share this resource with your treating oncologist. Another key resource to follow is our open studies webpage, where we list clinical trials that are recruiting ACC patients. Again, you can see the webpage highlighted in red. And lastly, ACCRF partners with ACCOI to curate a physician's list of doctors with experience in treating ACC. If your disease is at a stage where you're considering systemic therapy, you would want to focus on the medical oncologists as opposed to the surgeons, radiation oncologists, or interventional radiologists. As with the last 2 web pages that were highlighted in red, one of our ACCRF directors, Bojo Todoric, will put this web page into the chat for you to access. With that background, now let's turn to the real purpose of this webinar, a discussion with 2 top head and neck medical oncologists. To get things going, let me hand things over to our panel moderator, who is also ACCRF's Director of Research, Dr. Nikki Sparty-Bird. Over to you, Nikki.
Thanks, Jeff. I want to also extend a warm welcome to all of you attending the webinar and thank those of you who submitted questions. Panelists, you may now turn on your video and microphones, please. It's my pleasure to welcome two very active medical oncologists in the ACC clinical trial space to our webinar today, Dr. Glenn Hanna and Dr. Alan Ho. Dr. Hanna is a head and neck medical oncologist at the Dana-Farber Cancer Institute, where he serves as the director of the Center for Salivary and Rare Head and Neck Cancers. He is also an assistant professor of medicine at Harvard Medical School. Dr. Alan Ho is a medical oncologist at the Memorial Sloan Kettering Cancer Center, where he has been awarded the Jeffrey Bean Jr. Faculty Chair. He also serves as the co-chair of the head and neck subsection of the International Clinical Trials in Rare Cancer Initiative. ACCRF would like to start by thanking Dr. Hanna and Dr. Ho for their commitment to treating ACC patients and for taking the time to speak on our panel today about systemic therapy in ACC. Next, we'd like to invite each of the doctors to say a little bit about themselves, their work, and how they came to be treating ACC patients. Dr. Hanna, please start.
Thank you so much, Nikki and Jeff and all of the organizers. It's a privilege to be here with Alan, who I've come to know well over the last few years. And so as Nikki said, I'm a head and neck medical oncologist at Dana-Farber in Boston. And actually how I came to ACC was a little bit unusual in the sense that one of my colleagues was working on it who was a little more senior than me, and she had to unexpectedly leave our practice at Dana-Farber for personal reasons. And I inherited one of her clinical trials. And let's just say things snowballed from there. I took over the ATRA study and basically was told that there was this preclinical model for ATRA and that they needed to write and run a clinical trial. And whenever I sort of get my hands on something, I'm usually pretty quick to the draw. So we wrote the study, we launched the study, we published the study, as some of you may even know as being participants. And I was hooked. I just became enthralled by the science and the lack of options and wanted to get in early to make a difference in my career and hopefully see new drugs and new strategies for treatment. And I think it all came from the patients, many of which are you all. I realized that, a lot of the patients look a lot like me and are in sort of my footing of life, and I could identify with them and really wanted to be able to spend my career making a meaningful impact for them and you all as we move forward in this disease. So that's sort of how I came to doing ACC, and now thankfully I'm involved in a lot of the early and mid-stage studies. We're launching our own preclinical models in collaboration with ACCRF, and as you know, we are sponsored by a number of industry sponsors that give us drugs for use, as well as ACCRF and other grants to study clinical models, cell lines, and now even inpatient biopsies, testing different types of drug before surgery. So we're really trying to develop that Center for Rare Head and Neck Cancers and Salivary Cancers that we launched in 2020. And hopefully one day, along with Alan and my colleagues, we can bring drugs to fruition that have activity and benefit in this disease.
Thank you, Dr. Hanna. Dr. Ho, please share your story.
Yeah, well, thank you so much for having me this morning, and to the organizers, and sincere privilege to be here with Glenn and to talk with all of you and have this platform to reach so many of you that I know live with this disease every day. Yeah, my story is very similar. I trained at Memorial Sloan Kettering as a fellow. I did my MD PhD at Washington University in St. Louis. And during that whole training process, kind of decided that time that I wanted to apply my scientific knowledge into clinical trials and developmental therapeutics, and joined the head and neck service at Memorial. And I have to kind of credit my chief at that time, where we were kind of sorting out what I was going to focus on. And he said, I really think you should focus on adenoid cystic carcinoma, which for me came out of left field a little bit. It was a rare disease I didn't know very much about. But he really saw the need in his clinics every day. Just it's a much more prevalent disease than we really take for granted, and the lack of options. And he really saw the opportunity there to really make a huge difference. And so I really did appreciate that. It was intimidating at first because at that time, there wasn't a lot of scientific insights. There were a lot of biological trials. You had to kind of explain to people what the disease was. But it was also a very fortuitous time, because it was at the time where really our biologic insights in the disease really start to develop. The genomic efforts to really identify new targets was just happening. So, I really credit my chief for recognizing that need and positioning us at that time to really develop the trials that built off of the biology that came. And now you saw the chart that Jeff showed, just the amazing progress that's been made in research and the trials that are being innovated. So it's been, for me personally, so fulfilling in that way to be a part of that and to treat this disease and to get to know the patients that have it.
Thank you so much for those introductions. And again, thank you for your time, today, for being here. So now, without further ado, let's start with the question and answer portion of the webinar. Questions will be directed to the panelists in alternating order, starting with Dr. Ho. But all panelists should feel free to weigh in on any question after the designated speaker has finished their answer. Okay, so for the first question to Dr. Ho, there's no single journey for ACC patients, but can you describe some of the more common ACC journeys and when systemic therapy is considered?
Yeah, the start really depends upon at the time that you're diagnosed, what is the stage of your disease? And without getting into all the complexities of that, is your disease limited to the shoulder up or has it spread beyond there? Because, the intention of that treatment is different, So if you've got what we call locally advanced disease, which is tumor that's just shoulders up and it starts in your salivary gland or just involves your lymph nodes, at that point, the approaches are really what we call curative intent, trying to cure and eliminate the disease so it never comes back. And so the real important parts of your therapy are radiation and surgery and or radiation. If it's spread beyond where it starts, and that's where you start in your disease journey, then that disease is not necessarily curable, meaning like that the therapies we have will eliminate it completely, but we're really trying to manage it and keep it at bay for as long as possible. And for some patients, that also means just observation, because this disease, even though it spreads, can grow very slowly or not at all for months or even years at a time. So in that setting, the decisions one has to make is really about, well, do we need to treat now or do we need to treat later? And what are those treatment options? And those are the kind of complicated clinical decisions that we have to make. In terms of systemic therapy, typically when the disease is already spread, systemic therapy is often one of the most common tools in our tool chest in terms of therapeutics that we go through. And we can talk about the specifics of that. If you're in the locally advanced setting where it's shoulders up and that's where your disease started, the primary treatment modalities still are surgery and radiation. We will sometimes think about adding systemic therapy, drug therapies to the radiation to help the radiation work better. But certainly the most important components of your treatment for most patients in that setting are surgery and radiation.
Thank you. And for anybody asking questions in the chat about options for systemic therapy, we have a lot of questions that we'll get to this later on down the list. Okay, so the next question is to Dr. Hanna. What is your recommended screening schedule for ACC patients? When do you use CT, MRI, or PET imaging, and how often?
Yeah, so there's a lot of variation in how this is handled. I would say that in general, if someone is on surveillance or someone is even on treatment, my preference in the beginning is to gauge growth velocity is to do CT imaging, good contrast enhanced CT imaging, typically of the neck and chest and the pelvis and abdomen if it's necessary, if there are sites of disease in that area, at least every 3 to 4 months initially. If the disease is slow growing, sometimes we'll spread that out to 4 to 6 month intervals. But I think what's sometimes not ideal is that patients will undergo initial surgery and radiation to a head and neck primary cancer and then not undergo surveillance imaging of the chest. And as many of you know, that we know that ACC grows along nerves and can spread to areas like the lung and other areas like liver and bone in some cases. So we need to monitor those areas carefully. PET imaging is a little more limited. Many insurances won't cover it. And I would argue that it's not typically a fast growing cancer. So we don't usually see a lot of uptake on PET scans. So for me, I'm not usually recommending PET-CT unless it's under specific circumstances where I've gotten a CT image and I need to understand a little more clarity about the disease, or someone's had PET scans coming in to the first, into clinic, they've already had PET scans, and we'll use that as a sequential way of monitoring disease. MRI is also another case-by-case technology. When patients have local disease or nerve invasion in the skull or the skull base, that's where I'll sometimes think about monitoring with MRI, but in general, it's not always needed. We can usually get what we need from CT scans.
And as a follow-up to that, if a patient would have a suspicious nodule in the lung or the liver that's growing, under what circumstances would you consider recommending a biopsy?
Yeah, so this is, there's a lot of nuance to this and art as well. So for example, if someone has newly identified a disease that may be in the chest or elsewhere, and it's slowly growing over time, and clinically it's consistent with what would be an ACC area, I do, as Alan probably does, do recommend a biopsy at some point, both to understand the genomics of the tumor and any molecular findings, but also to confirm that it is indeed spread from ACC. Because remember, we can see patients with competing diagnoses who have multiple cancers. It could be a lung cancer and they have a history of ACC as well. So definitely to confirm for the first time that there's distant disease, and to get that critical molecular information that will come up when we talk a little bit more about treatment options. Now, going forward, when someone has known advanced ACC and is on sequential therapies for treatment, we do sometimes recommend biopsy at intervals. In some of my patients, I will recommend repeat biopsy in some instances where there's a question of one site that's growing really quickly, or if we haven't gotten adequate genetic information for a long time. Because some of the older gene testing isn't as comprehensive as what we do now with our in-house panels, like MSK has their snapshot panel or impact panel, or onco panel. There's also commercial assays like Tempus, Caris, Foundation Medicine, Foundation One. All of these things are newer and have larger gene panels that have 300 to 500 genes that we can test. So in those instances, we may want to update the genetic information to understand more about an individual's ACC cancer. So those are kind of the circumstances where you probably want to consider rebiopsy after you already know someone has advanced disease. And finally, many of you all know that when you enter a clinical trial, we often ask you for a new biopsy, and that is for learning as much as we can about the therapy you're going on, but also sometimes to update the gene information.
Thank you for that. Okay, the next question is to Dr. Ho. When do you feel that watchful waiting is no longer the right path for recurrent metastatic ACC patients, and that it's time to start treatment?
Yeah, I mean, I honestly think this is one of the most challenging questions that we face clinically. And as I mentioned, in this situation, we're really trying to control the disease. And the two things that you're really trying to balance here is the fact that, well, on the one hand, some patients can have very slow growing or stable disease for months or even years. And so you really don't want to give patients treatments or expose them to risks of toxicities until it's absolutely necessary. And so I think all of us in the field agree that giving patients that time where they're feeling well and don't really need therapy is really important to preserve. And you want to balance that against the tension of really wanting to be active and giving treatment when it's necessary. So this has to be done on a case-by-case basis. One of the things that we don't have is really kind of an algorithm that applies to everybody that can be used to kind of predict these things. And so some of the factors I always look at is, of course, the patient's overall health, and how they're feeling, whether the tumors are causing symptoms or will cause symptoms soon within the next year or so. And then within the tumors themselves, it's really about distribution, what organs are involved, size, and then rate of growth. And then lastly, as kind of was alluded to in the chat, increasingly we're using genomics to help us figure this out as well. as we kind of identify different genes in the tumors that we know that portend a little bit more aggressive disease that we can be a little bit more proactive about. So you have to kind of take all those things into consideration, and certainly in the context of the patient's overall health.
Thank you.
Can I ask either or both doctors, how do you see patient preferences impacting those decisions? Are you seeing a wide range of involvement of the patient?
Yeah, absolutely. I mean, I should have mentioned that too in that list of things that we take in consideration, because there are some consults that you'll have and the disease is behaving such, or the biology is such, that you say to yourself, you need treatment, period. This is a short discussion, or there are other situations where the disease is really small, there are no symptoms at all, not growing, and that's also, to me, a short discussion. There's no way I would expose you to the risks or toxicities of treatment. But most of our consults are the in between. There's a little bit of growth, and what are we going to do about this? And there's certainly there, I think, is where the breadth of patients' preferences come into play the most. And you want to really kind of take that into consideration. There are patients who are want to be proactive, and the growth justifies that treatment, and where maybe you lean a little more towards treatment and taking patients that journey. And others who are really feeling great and really want to kind of defer systemic therapy for as long as possible, and you have to respect that as well. Because part of this is not only treating the disease, but treating patients' psychological health, and how they view their disease and how they really want to take ownership of their treatment. And that's a huge and important part of this. So, in that gray area, there's a lot of that's where a lot of those discussions happen.
Yeah, I would agree. I guess one thing, building on that, is that patients more and more now, because you all are so interconnected, and because you're all, the ACCRF does an incredible job of educating the community about options and trials. Many of you come to us as, experts in the field with a particular therapy interest in mind. And it's really, I always try to go through the landscape of options with all of my patients in that moment and what's coming. But in general, sometimes there is that predetermined sort of interest in a particular therapy or therapy class. And much of that, let's be honest, comes from your experiences talking to each other about benefits and lack of benefits or side effect profile. Dare I mention the vascular drugs and their side effect profile. Even if they have a response rate, there are patients who just are not willing at that time in their disease or their journey or natural history to embark on those drugs. So I think that's part of Alan and I's strategy too, is sort of making sure we recognize the input you receive from the community and how to handle that going forward. So there is a huge patient-specific element to guiding one to therapy.
Thank you. Thanks, Jeff, for that follow-up. That was, obviously very, I think, helpful. There's a lot of details here. Okay, the next question is to Dr. Hanna. When it's time to treat an ACC patient with metastases, when might you consider radiation or interventional radiology approaches like RFA ablation or surgical resection instead of systemic therapy?
Yeah, so a couple of pearls here. One, it depends on the expertise of the center you work in. So I'm sure Alan and I are both fortunate in that we have interventional proceduralists, very, very talented radiation oncologists who can do these sort of more advanced procedures like chemoembolization or radiation to the liver, radiofrequency ablation to the lung and liver, as well as radiation, even external beam radiation to some organs like the liver, and larger lesions. So, and cryotherapy too. So cold related therapy is another example of a targeted treatment. So when to do it is a little bit tricky. Generally, if there's distant disease and it's sort of uniformly slowly over time, that's not when we typically recommend doing a locally targeted therapy. However, in some scenarios where one site is growing more quickly, for example, many patients have observed their liver spots grow a little faster than their lung spots, and the liver may have a little less reserve, we might recommend something like an ablative therapy to the liver. The other is, what is the likelihood that that site of disease is going to cause critical impingement or symptoms or side effects? So that would gauge or determine whether we recommend doing something locally ablative. If you have lung metastases, but one of them is on the chest wall and causing pain and pressure, we may recommend treating that one lesion with short fraction radiation or targeted ablation as a way of immediately alleviating those symptoms. So all of that goes into the determination of when to use some of these more integrative therapies. And I did see a question come in about, do these localized options change outcomes and long-term natural history? We don't know. We don't know if giving someone early treatment with focal therapy means that the larger tumor burden slows down over time and that someone will live longer. But we're actually investigating that in a clinical trial now at the Dana-Farber and opening some other sites where we use low-dose radiation to up to 5 spots when someone is newly diagnosed in the first few years with advanced ACC to see if we can kind of slow down the burden of disease, improve the time, or I should say delay the time to a systemic treatment and hopefully improve outcomes. So we're actively looking at this, but it isn't open these local to impact the natural history of the whole diagnosis.
Yeah, I think, Glenn, you may have been garbled there at the very end. ACCRF, monitoring all the patient chats, getting all the information back from the community, we realized that there's an enormous uncertainty about, well, which, do we try systemic? Do we try SBRT? Do we try brachytherapy? Do we all these different options? And so, that's why ACCRF is actually supporting the solar trial that's currently open at Dana-Farber and will be open at a few other sites to try and get a sense of whether treating just a few ACC metastases can improve outcomes.
Okay. I think up till now, we've talked a lot about the context and the nuances about, when to treat and deciding, really when is the right time to undergo systemic therapy. But this next question now is kind of moving into more, again, nuances of what are the main options for systemic therapy for ACC patients? This is to you, Dr. Ho. And is there a developing standard of care?
Yeah, I mean, well, just to cut to the chase of the last one, in my view, there really isn't one standard. And, I think what happened in the last 10 years or so is just an amazing amount of clinical trial activity that really kind of highlighted new drugs that could be useful in the disease. But in the beginning of that, it was really about smaller phase 2 trials demonstrating proof of principles or activity of different classes of drugs that we can talk about. And now we're kind of graduating the field into like larger studies or even randomized trials that maybe will be very helpful for establishing, that golden standard of care. And so the treatment options have definitely expanded, but, we're not there yet, in my view, in terms of like what is a standard go-to drug that everyone has to start with. And the truth of the matter is, of course, is that most patients will go through many different treatment regimens. And so the order in which some of these can be administered or the most beneficial order in which they're given is really not very clear. So when I see a patient and I think systemic therapy is needed, the first thing I go to is trials, because we've made some amazing progress, but we still need more, and the prioritization of clinical trials is a huge focus for all of us, Glenn and myself and all of our colleagues right now. And as that graphic demonstrated, the activity and the amount and choices of trials has really kind of exponentially increased. And so we can talk about those specifics, but there's so many different classes of agents that are being evaluated at this point. And I think a clinical trial would be most helpful. Outside of a trial, the things I do think about include, chemotherapy. So not everyone uses chemotherapy, but we use kind of some of the older phase 2 trials that have demonstrated some regimens that can shrink tumors and we've seen some activity with, and it's only a short list of agents that have some usefulness. So we have some chemotherapy agents that we consider. The second class is the class that Glenn had mentioned, which was these vascular targeted therapies. These include drugs like lenvatinib, axitinib, and other agents that are in clinical trials like ribociclib. And as a class, we know that they have some modest activity in terms of shrinking tumors or even prolonging the time that you can control disease. But like anything else, you have to balance the risks and benefits of those toxicities in that class. The third bucket I often think about are the genomically driven thing. So if in your genetics, you find something that is eminently targetable, whether it be off-label with the drug or on a clinical, or preferably on a clinical trial, those are often things that we will prioritize and think about. And the last bucket is, kind of immunotherapy type of approaches, which I think we'll discuss later, but, we can get into the details about that when those questions come up. But those, to me, have to be investigated in the clinical trials, and different avenues and approaches that are being evaluated will be important for that.
Maybe as a follow-up, since you brought up chemo,
Yeah.
and we talk about this a lot, and a lot of times you'll hear, that ACC tumors are chemo resistant. Either to you, Dr. Ho, or Dr. Hanna, is there a time when you, or a type of patient or a type of tumor that you would really consider treating with a chemo?
Well, I think this even more broadly goes to all of these options, because they do have different side effect profiles, routes of administration that may be of benefit or detriment to one patient versus another. And so when I'm thinking about chemotherapy versus the oral drugs, I'm often considering those profiles and what patients can tolerate, what's safe to give patients, and what makes the most sense in that situation. So there isn't a biologic phenotype or like a clinical type of disease where it's chemo over like lenvatinib or that sort of thing. But usually it's more about side effect profile and what patients are able to tolerate. Now, in all the TKI studies, most of those patients were previously pretty heavily pretreated, meaning that they had gotten chemotherapy before, et cetera. So we know that some of the activity seen in those prior trials persist and can exist after chemotherapy. So at least you have some data supporting that approach.
Okay, the next question is to Dr. Hanna. Oh, sorry, Jeff, yes?
Yeah, my impression, which I'd appreciate either of the physicians to comment on, is that often chemo might be used in a shorter term with disease that's very aggressive, sort of to that type of patient. And also, I think, as Dr. Hanna mentioned before, it's a chemosensitizer during radiation. So there might be, those are maybe a couple of other times. Is that correct?
Yeah, I mean, my preference is rapidly evolving disease where a trial is not feasible just for timing purposes. When someone has tried many other agents, VEGF, immunotherapies, agents and trials, as you said, as a sensitizer in some cases to enhance radiation.
Yeah, and especially, the radiation chemo question to us, makes a lot of sense when you're irradiating gross disease, meaning like there's tumor there you can see and you need to treat, because you really need to amplify whatever effects you're getting from the radiation. And then it's the tougher question about what you do if after you resected the tumor and now you're getting the radiation after your surgery to kind of consolidate what the surgery does. You could argue in that situation, radiation alone is the standard, although we do sometimes look at people's risk factors and kind of decide then whether we want to be more aggressive with the chemo. And then those have to be taken on a case-by-case basis.
Thank you.
Okay, the next question is to Dr. Hanna. Do you expect all drugs to have the same effectiveness and side effects in all ACC patients?
This is a difficult question. I would say no. I think the issue becomes that some patients will have more side effects than others. And actually, I apologize. Alan, do you want to take this question? I just need to get a little noise in the background.
Yeah, sure. No
Sorry
problem.
about that.
Yeah, no problem. Yeah, well, just kind of what I alluded to in the prior question was, we do know that patients will have different tolerance of different treatments, sometimes whether based upon their comorbidities, meaning, what other diseases or medical issues they may have, whether they have heart disease or difficult to control hypertension, diabetes, et cetera. So part of the decision-making about choices has to do with, well, the anticipated side effect profile of the drug that you're using and how that matches up with patients' medical history. And then also overall fitness as well. We also have to assess to make sure that, whether one drug versus another will be best tolerated by a patient by where they are at that moment in time. Did they just get released from the hospital and are a little deconditioned and a little weak? Do they need time to kind of recover to a stronger stage before you can really assess that the safety and the efficacy of the drugs in those situations? So the broad answer is yes, you have to kind of take consideration of all those individual traits and then match it to the anticipated side effects of the drugs that you're considering and make the best choice.
As a follow-up to this, we talked a lot about TKIs and their more broader use. And if a patient progresses on one TKI or can't tolerate it for whatever reason, is there a rationale to try a different TKI in that class?
Maybe I'll comment. So I typically don't rotate different TKIs with some few exceptions. So, and Alan can comment because some of this speaks to the art of the disease, but I would argue that if a multi-targeted tyrosine kinase inhibitor towards the vascular pathway, which is what these drugs are, it works and then stops working. Hard to envision that giving a drug with the same sort of class effect is going to have more benefit. But here's some caveats. I have actually rechallenged patients with a different class of VEGF in some instances. One is when I'm combining the therapy with something else. So to Alan's trial, which is combining lenvatinib, a VEGF inhibitor with immunotherapy, in some instances, my patients know that I will do that off-label even after they've had a single agent vascular drug. Another option is I've had patients on the new rivasirnib trial who have come off the study for particular reasons, whether it's they've dosed too many, they've dropped too many doses, or they've run into side effects, and the trial is very strict. I've actually moved on to targeting those patients with something like lenvatinib and had good success. So if I'm switching for drug-specific reasons or I'm adding something, I do re-challenge. But for my practice and from my knowledge, and Alan can comment, I haven't jumped from lenvatinib to axitinib to rivasirnib in sequence in the absence of data that suggests that's a good idea.
Yeah, I mean, I think all of our, it's like one of the central tenets in oncology that, especially if you've got different classes at your disposal, if you're resistant to one class of drugs, you always prefer or prioritize going to a different class. Right. And like I said, I think, we are we always need more, but we're in a situation where there are different options that one can consider. And it's not as if I do it routinely, but I do sometimes use TKIs afterwards if those options don't exist, because there are some precedents for that in thyroid cancer or kidney cancer, where you can use these things sequentially, because even though they hit the same molecules, they're not entirely redundant. In some of the trials that we've done, even the ones that didn't demonstrate the most activity, you did sometimes see regressions in patients that went from TKI to TKI. So the data is not strong where you would have to say you definitely have to do it, or this is definitely an effective approach. And like I said, we always try to prioritize switching people from class to class, honestly. But in my view, they do represent other treatment options. And then the last point is, and this is not supported by any data at all, but sometimes if you separate it out, like you did lenvatinib, and then you went to another agent, and then you went to axitinib, there may be some biologic reasons why that might be a little bit more advantageous, in terms of like the clones. What we don't all realize is that within the tumor itself, or within one patient's body, the ACC cells are not all identical, and so you could certainly see scenarios where treating with one approach would kind of cull out certain cells, and then treating with a different approach will cull out a different type of cell, and then going back to the older class of drugs might have some value there rather than doing them sequentially. So, in the absence of data, these are kind of the rationales that we kind of go through and think about when thinking about these approaches. But yeah, that's what we need, is more trials and more data to kind of support those approaches.
Thank you for both speaking to these nuances. And I think, again, it's important to reiterate that this is all emerging biology, and hopefully we'll continue to learn in this space more about these kind of questions. Okay, so the next question, and we've had lots of chat about this. This is going to Dr. Ho. Describe how and when you would use tumor profiling to aid your treatment strategy, and are there drugs that you would pick based on the results?
Yeah, I mean, I think all of us use tumor profiling in everybody, honestly. That's our priority, frankly, whether it be through liquid biopsy or genomics of a tumor. Because on the one hand, as a general strategy, this is a rare disease, and we are all looking for the most effective treatment. And regardless if a mutation occurs in 50% of the tumors or 2%, we want to find that 2% for each individual patient, because that could represent the best treatment option. In ACC, relative to other diseases, it's not the most abundant in terms of targeted approaches, but the other aspect of this that's really important is that innovation is changing at such a rapid pace, and the classes of drugs that are is being developed at such a rapid pace that genetic alterations we find in an ACC patient today may be targetable in 3 months from now. And so that information to me is invaluable. There are targeted approaches like Notch that I think we'll talk about later that will be directly relevant. But typically, I try to use tumor profiling in some form or fashion for almost all my patients.
And as a quick follow-up, would there be differences in when you would use or how you would interpret tumor versus blood profiling?
Yeah, I think this is an emerging aspect of how we're diagnosing the disease and following the disease. There are certainly advantages to blood profiling with data coming out now that demonstrates, maybe it's a little bit more of a pan view of different tumors within your body. Like we were talking about before, not every tumor in your body may not be identical. And so the biopsy of one may not reflect all the genetic alterations that exist in your tumor in total. Still, probably the most important targets for drug therapy are the ones that are concordant or existing in all your tumors, are kind of what we call the truncal alterations. So certainly tumor genetics still plays an incredibly invaluable role, and many of the trials that we enroll to will often enroll based upon the tumor genetics rather than the blood profiling at this point, although that may change, that's slowly changing. So, in some scenarios I'll do both, but almost everyone will get tumor profiling. And then if we're searching for more targets or there's more desperation to find different things, we could consider blood profiling as well.
Okay, thank you. Next question to Dr. Hanna. If I'm a patient and I've been told that I have a Notch mutation, what are the implications? Can you tell us more about systemic therapy options for Notch positive ACC?
Yeah, so as many of you know from work done by Renata Ferraroto down at Anderson, who also is a big proponent of treating this disease, we know that Notch patients have a greater propensity for worse outcomes and early spread of disease and perhaps more aggressive disease. So we often will treat them a little bit more aggressively, starting treatment sooner. Clinical trials are the preference. So we're not totally sure which particular types of drugs that we have available, like immune agents or vascular drugs, are optimal for Notch patients, but there are a couple of drugs that are Notch targeting. There were some old Notch receptor inhibitors that unfortunately didn't really pan out in terms of solid benefit. More recently, Dr. Ferraroto published data and will publish sort of the final trial soon of the accuracy study, which I believe Dr. Ho participated in, using a drug called AL101 from the company particular pathway in the Notch signaling cascade, how Notch, which is a gene, is activated and switched on to make the cancer grow. And this drug has some tolerability issues, as many of you probably know, in terms of GI issues, and is given IV weekly, but has shown some activity, response rates anywhere from maybe 10 to 15% roughly, meaning tumor regression. So unfortunately, it can be short-lived, but that is an option, and hopefully ILA is able to move forward to develop that drug. This drug comes from Europe. This is a pan-oral Notch inhibitor called C103 from Celestia. And this drug is actually under investigation now as an oral agent to block ACC tumors.
So I think Glenn's audio is cutting out a little bit, but patients should be encouraged to check out our website, which has clinical trials, and we feature a bucket that is specifically for Notch active ACC patients trials that are open for those folks to find out some more. Okay. All right, the next question, and we've touched on this a little bit. So if there's anything new we can add here, but it's, it can be overwhelming for a patient without medical knowledge to decide whether to go on a clinical trial, and if so, which one should they pursue? So maybe you can talk a little bit to that, and then we're getting some questions from the chat about, do you consider remote consults for folks that maybe are unable, geographically to travel to MSK or Dana-Farber, even from those folks that, may be in Europe or abroad?
Well, the remote question, yes. It's always preferred that we see patients in person first, because, to kind of get the total sense of where people are at. But yes, of course, we do telehealth visits and consults for patients. There's some states where that's not possible. So if there are questions about that, obviously reaching out to our offices and is certainly advised, and we can kind of provide some guidance there. In terms of clinical trials, yeah, on the one hand, it's amazing that we have so many options, and I can understand it would be incredibly overwhelming to make those type of decisions. And the only thing I would say there is just, one has to, the whole issue with treatment on a trial or off a trial is not only making the best option for yourself, but also making sure that you're comfortable with those choices. And part of that comfort is really being empowered with understanding why those choices are being made, why those trials are being done. So, anytime you're offered a trial, it is not only fair game, but mandatory that you talk with, whether it be Glenn or I or whoever it is your treating physician, about why that trial is being offered, what is the reason the trial had been developed, and anticipated side effects, etc. All these things by definition are experimental, meaning that we don't know the answers to all of those questions, or specifically the outcomes in adenoid cystic cancer patients. But there's enough there for to make sure you're informed and that you're comfortable with those choices.
Okay. And in the chat, I'm seeing a lot of questions about specific trials, and asking the researcher, the doctor, to comment on how promising does a certain trial look like. And I think what I would encourage everyone on the webinar is to sign up for our research updates that we send out a few times a year. It's there that we will, sort of highlight any trial that has closed or that has published their results either at a conference or with a paper. And you really can stay, I think, the most up to date through that mechanism. Okay. So the next question is for all of our panelists, Dr. Ho, Dr. Hanna, and Jeff. What systemic therapies on the horizon are you most excited about? Okay, who should go first? Let's see. Dr. Hanna, why don't you go first? Okay, maybe his signal is. Are you? Okay. Can you respond, Dr. Hanna, first?
Yeah. So maybe, and as you know, I'm trying to I have great connection, but for some reason I'm cutting in and out. So I'm doing my very best to stay keep up with you all. But in terms of couple of thoughts. One is everyone is excited about the PSMA targeting immune effector cell, CAR T cell product. So this is taking out your own cells. We know that ACC expresses the PSMA receptor, and we take those cells and we send them to a company called Poseida, and they manufacture them to be very strong, and then they put them back into the patient, or sort of we deliver them back into the patient as a living cell therapy. That's a very exciting opportunity, but that trial is very early in development, and obviously there's a lot of risk reward with that, because while it is the early cell, it requires high dose chemotherapy to make room for the cells, and then delivering the cells under sort of monitoring conditions. So a lot of patients are asking and very interested, but that would be one that I'm much excited about. I'm looking forward to the CD103 data, the pan-Notch inhibitor, as the next generation of Notch drug for our Notch8 mutant patients. I'm excited about Alan and Renata's data looking at immunotherapy in combination with a vascular drug. I think that is a rich combination that we're very interested to see the efficacy results of. There is a next generation PRMT5 inhibitor, which basically what's called an epigenetic modifier that puts different flags on DNA that's up and coming. And finally, for me, there's several companies working on a new oral MIB inhibitor, so new ways to modify or target the MIB protein. There's two companies, which I can't say too much about, that are looking to bring their drugs into clinic in 2022, 23.
Thank you. Dr. Ho.
Yeah, I mean, the only thing I would add to all of that is, just kind of broad comments is, trying to develop approaches that are personalized to tumors. In kind of what Glenn is mentioning in terms of the excitement over PSMA, et cetera, is because we know that there's a specific target that we're going after there. And that's where the excitement is being able to personalize these things to specific proteins or genes that are in patients' tumors and developing more trials like that. And so that speaks to the MIB stuff and everything else. And then the other bucket that I think we need to move forward in is that Glenn mentioned is just figuring out immunotherapy, because all of us, whether it's the CAR T cell approach or improving upon the T cell checkpoint inhibitors that have been mentioned, they, on its own, the data to date suggests that they just don't work well enough in enough adenoid cystic cancer patients. But when they do work, they work remarkably well. So it's that challenge of making sure that we innovate new approaches and therapies so that we can broaden that immunotherapeutic effect to more patients, whether that's through combinations, new drugs, CAR T cells, et cetera.
Jeff?
Yeah, I'm going to piggyback a bit on a couple of things that Dr. Hanna mentioned, and that really relates to our impression that ACC is a disease primarily driven by a gene called MIB or MIB-L1, and ACCRF in the early days, has spent a lot of time trying to identify drugs that exist that could be repurposed into use for ACC. And so we looked for, we had grantees that would screen for drugs that would inhibit MIB. And that's what led to the trial that Dr. Hanna run for ATRA. That was a pre-existing drug that was being repurposed to ACC. What is so exciting is that now in the last few years, instead of me going to beg companies to give their drugs for us to test in our preclinical models, companies are coming to us now and saying, we'd like to screen our drug, where we're creating drugs specifically for MIB. We understand that ACC is a particularly important disease driven by MIB. And so we're getting drugs that are working their way through that pipeline I described before. And they didn't just appear out of thin air. It's coming out of a steady preclinical process, research process, where I think over the next couple of years, we could get some really, really exciting drugs that attack what we feel is the main driver of ACC MIB. So that's my most exciting development.
Great. Okay, I think we are just at our time limit. We're at the hour, so I'd like to close the panelist portion. of our webinar by thanking Dr. Hanna, Dr. Ho for their time and for sharing their invaluable insight with our audience today. I've been at the foundation since 2016, and one of the most rewarding parts has been meeting and befriending passionate and motivated scientists and doctors like you both. Because of your work and commitment to the field, I feel strongly that patients should have justifiable hope that better therapies are on the horizon. So thank you again for your time today and your commitment. And now let's turn it over to Marnie Kaufman for a final farewell.
Okay, so all I can say is wow. I mean, seriously, listening to Dr. Ho and Dr. Hanna, it makes me so grateful that these brilliant and thoughtful clinicians are so focused on researching ACC and treating ACC patients. I mean, we are so incredibly lucky. Jeff, if you can share the last slide. We just want to make sure that these webinars continue to be about education and hope. And we want to make sure that we're providing you all with the information that you need to make knowledgeable treatment decisions and to enjoy your lives. Okay, we truly value your feedback, and we'd love for you to let us know one thing that worked well today, one thing that could be improved, and any other topics that you would like us to cover in the future. You can either email us, you can see it info@accrf.org, or you can, or you can put it in the chat, and we're going to keep the chat open for a while after this session, just so you can leave your comments. So once again, I want to give a huge, huge, huge thank you to Dr. Hanna and Dr. Ho for spending time with us today. We've learned so much from you both, and you give us even more hope for our futures. We hope this was helpful for everybody. We'll be posting the recording of this webinar on our website, and we look forward to keeping the discussions going. We hope you enjoy the rest of your day or your evening. Take care, everyone.